and welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ, and tonight we're talking about breast cancer surgery. Before we get started, some housekeeping. I encourage you to make the most of the chat box during the webinar. At the bottom of your screen, you'll see a taskbar or status bar, and if you can't see it, you might have to move your cursor down to that area to make it appear. On that bar, you'll see a chat icon. Click on that to open the chat box. If you have any technical issues, you can type the details there and our support team will get in touch. You can also use the chat box during the webinar to ask questions, which we'll get to later, and you can chat to other people there. Don't worry about missing out on information while you're chatting. The webinar is being recorded and will be available on our website tomorrow. Right now, you should be able to see us panellists in a small box on your screen. If you want to make us bigger, just drag the corner of that box. So tonight we're talking about breast cancer surgery. For most people, surgery is the first treatment they'll have, and nearly everyone gets there eventually. But the surgery you can have varies depending on your cancer and your circumstances. Tonight we're going to talk about the options and about preparation and recovery. We have 4 speakers tonight who will share with us. Our first 2 speakers are patients, Shona Herndl and Greta Thomas. They'll share their quite different experiences. Then surgeon Dr. Aletha Taylor will talk about the different surgical procedures you might be offered. And lastly, Nurse Katrina Farrett will give some tips on getting ready for surgery and what happens afterwards. So first, Shona, just move that on, who was diagnosed 3 years ago. Shona, tell us about that and the treatment you had, particularly the surgery.
Certainly. So, hi everyone. I went for a routine mammogram at one of the mobile units in 2018. I was called back and had an ultrasound, mammogram and biopsy. They discovered a 3.5 centimetre tumour that was HER2 positive. I went through a regime of treatment. It started first of all with chemotherapy before the surgery. I had 6 rounds of chemo, which shrank the tumour by 90%. I coped well and worked throughout. I was self-employed, so I could give myself a couple of long weekends. Your body tells you when it's time to stop and rest, so it's always really good to listen to the body. I then had some radiation therapy, and that was a little bit daunting at first, but once you're in the rhythm of the visits, it certainly becomes easier. I developed a couple of blisters, but they healed quickly. As each day passes, you're closer to completion. I had Herceptin as breast cancer was HER2 positive. Then we had the partial mastectomy. I needed to go to hospital overnight. And once the surgery was over, I was back home by lunchtime the next day. The wound healed very quickly. It was a little bit scary. I'd never been in hospital before for myself, so I really didn't know what to expect. And I also didn't know what my breast was going to look like afterwards. But I was determined to stay positive, as that I knew that it was important to do what was necessary. Now I look at my scar in the mornings and I kind of feel like it's my symbol of courage. I totally trusted my surgeon, and I believe that relationship is really important. So where am I today? Well, I have follow-up appointments with my doctors and I have an annual mammogram. However, after the treatment, and I remember leaving the hospital on that last day of Herceptin, just driving down Remuera Road going, but now how do I live? At that same time, I saw an opportunity to go on a cancer healing retreat, and that certainly has changed my life. So from that cancer healing retreat, I learned a tremendous amount. So I sold a training business that I'd had for 20 years, and I've started a new business supporting others going through the cancer journey. I look back now and I'm really grateful for the cancer journey. Cancer has given me many gifts that I never imagined. Today I feel great and I have good energy and I have a new energy for life. I find joy in small things and I live more in the moment and don't worry too much about tomorrow. Cancer gives you the opportunity to find courage that you actually never knew was deep down in there, but it's there. Thank you.
Oh, that's great, Shona. Thank you so much. That was really very inspiring for people. If you're at home, don't forget to use the chat box to talk to each other or to submit your questions, and we'll come back to that later on. You can also look at the conversation there. Our next speaker, Greta Thomas, was diagnosed just last year and is still in the early follow-up stage of her treatment. Greta, thank you so much for joining us. Could you share your story, please?
So yes, my name's Greta. I was diagnosed with cancer at the age of 39. My mother has had breast cancer. I should click along, sorry. My mother had had breast cancer twice and so got tested for the BRCA gene, which turns out she had. So I ended up getting tested as well. So I started having mammograms early. I actually had a mammogram in February, which they said was all clear. And so when I found a lump in May at the end of lockdown, they kind of didn't think it was breast cancer as such, because they said, oh no, you're all good, your mammogram was clear. But I found out later that apparently the younger you are, the more dense your breast tissue is and it's harder to see. So my first bit of advice is really trust your body and trust your gut instinct, because then I pushed going, no, you need to actually check this out. And so the lump actually came back as positive, obviously for cancer, stage 2, grade 3, triple negative breast cancer. But one biopsy did say that I was very weakly estrogen positive as well, thrown into the mix. Because of the aggressiveness or the activity, as they described it, of my cancer cells, neoadjuvant chemotherapy was recommended. So I went into chemo first as opposed to surgery. So in that sense, those that are, because this talk is about surgery, those that go into surgery straight away, you kind of have less time, whereas I was able to go through chemo, which was pretty brutal, quite an intense chemo, the first one. The second one was a little bit easier to deal with. But I had time to think about surgery, whereas some it just, you'd get rushed in quicker. The thing that I went to I guess it's called a seminar about breast surgery and having mastectomies and reconstruction, etc. That actually freaked me out even more. I really didn't want surgery. I'd never been a person who wanted a boob job. Had never crossed my mind. I'm quite a sporty, active person, and I was like, no, I'm quite happy with what I've got, thanks. So the thought of it actually really freaked me out, and that talk, which I thought would help me, it freaked me out more, because all I saw was the scars and the skin grafts and the reconstruction that the surgeons, who are all, amazing doing their job, were saying, look how good this looks and that, but I saw the negatives in it, and so it just freaked me out. So I wasn't confident going into surgery. I also, like I said about trusting your body, I'd also say, and I think Shona brought up as well, about having trust in your surgeon. So the first surgeon I really didn't feel comfortable with. I'd had a bad experience right at the start of the diagnosis, and I just didn't feel comfortable. So when they came back saying that was still my surgeon, I asked to change, and I don't regret that, because my next surgeon was amazing and I did feel a lot more comfortable and confident with, so I went in with that. So I also didn't have the option, well, you always have an option, by the way, I should point that out, but it was recommended that I have a double mastectomy, so bilateral, because of the type of cancer I had and because of the gene, my risk was really high. So I knew I was having both off. And so, yeah, that was a little bit scary, because I didn't know what I'd be waking up to. They basically said to me with surgery that it would be depending, once I was under where the tumour was, to if they could save my nipple, if they could save my skin and that kind of stuff. So I had no idea what I'd wake up to. On the day I actually felt really calm, and I went in, and I don't know why, after being scared, but it was quite calm, went in, and when I woke up and saw that they were able to save my skin and my nipples and I looked normal, I was like, oh, okay, I got this. So surgery, so in that sense, went really well. But yes, I had these big drains in and lots of discomfort. They also said, and so this I guess would be advice for people getting ready for surgery, they said you'll be fitted with a bra and things like that. And then when I got there, it was like, oh no, we're out of stock, you need to go get them. You're in pain, you can't move your arms, and you have drains, and you're like, I'm not going bra shopping. So have support people, really, and do have a bag ready, which I think you might talk about tips and stuff like that. So yeah, be prepared, have stuff. My recommendation, I brought them along, is after trying multiple bras, and I had a really wonderful husband who went bra shopping for me while I was in hospital. And the Kmart bras, I don't know if you can see, so they've got the zip at the front, they're soft, nice, wide at the back, and they're comfortable. They come in so many different colours as well. They were amazing. So even over the way more expensive ones, because he went out and got a variety of sizes, because he was like, I don't know what you need or what you are, and he just went nuts, and I'm like, you rock. But get yourself some Kmart bras before you go in. Don't trust that they'll say, don't worry, you'll be fitted with a bra, because that's not always the case. And so yeah, be organised for yourself, have some button-up pajamas and stuff. I found that that was really helpful. So yeah, having a person that can do stuff for you was really good. I did have to stay in hospital a little bit longer, and again, trust your body and listen to your body. They tried to send me home sooner. On like day 2, I said, I'm actually feeling worse, I really don't feel well. They said, no, go home, you'll feel better. I waited a couple of hours for my husband, and when he got there, next thing my blood pressure dropped, and emergency people came in, and then they were like, yeah, you need to stay another night. And I'm like, I tried telling you that all morning that I was feeling bad today. So trust yourself, speak up. The other thing about surgery is after I said, look, you know, what exercises should be doing, because I wanted to get movement back and all that kind of stuff, and do I need physio? They said, no, just rest, go home, you'll be fine. I developed what was called cording, but I didn't know that at the time. And I thought, oh my gosh, when they've taken my lymph nodes out, they've done something wrong, they've stitched something they shouldn't. What is this? I can't move my arm, and it's like this big rope down there. And then a lovely nurse from the Breast Cancer Foundation phoned me and said, oh, we can send you, you know, a pink card for physio. I went to physio, and she said, why don't you come sooner? And I'm like, but I asked, and I asked all the questions, and I was told not to. Her first appointment made such a difference. So again, listen to your body. That's definitely my go-to throughout this whole talk, is listen to your body. And so within that first treatment, I was like, oh my gosh, I can move my arm. This is amazing. So that was all to do with the surgery and the recovery. And just, yeah, so if you aren't feeling great, there is help out there. What else do I need to say? Let people help you. So I'm not good at that. I'm just like, no, I'm right, power through, do all that kind of stuff. But I realised I'd get home and I'd collapse on the floor exhausted from chemo treatments after surgery, whatever, all that kind of stuff. And then the times people just showed up going, I didn't listen to you, here's a meal, I was actually super grateful. And I'm like, I should have just said yes to the other people. So yeah, just let people help, because even if it's hard to accept help, and trust and listen to your body. So I'm still having treatment because of the type that I had after surgery, and I recovered from that. So I'd had chemo surgery. They then said to have more chemo to give me the greatest chance of survival and the greatest chance of it not coming back. So I am actually on chemotherapy right now. I'm also on another drug for 5 years, if I last that long. I can say that. And I also have to have an oophorectomy, my ovaries out, because apparently the type I had and the gene I had means the link to ovarian cancer is quite high. So I've still got quite a bit of a journey ahead of me. But yeah, just ask questions, ask for help, and just listen to your body would be my biggest advice. And you go to Kmart. I'm not even a Kmart person, but you know what? These bras rock. Thank you.
Wow, Greta, thank you so much. There was so much good information there and really good tips for people. So really thank you for sharing that. It's really, very, very helpful. Now we're going to hear from Dr. Aletha Taylor. She's an oncoplastic breast surgeon. Where's the little surgeon? Oh, there we go. So Aletha is an oncoplastic breast surgeon at Auckland City Hospital and at Breast Associates. Aletha, we've heard 2 quite different stories tonight. What goes into deciding on the best surgery, and what actually happens with the different procedures?
I'd like to start by saying that's not the first time I've heard about the Kmart bras. They get a resounding seal of approval from a lot of my patients as well. There's a lot of stuff that goes into figuring out the right kind of surgery for women, and there's lots of different things that tie into why one might be a better option for one woman over another. As these two lovely ladies have talked about, we are looking at chemotherapy first for a lot more patients than we used to. But broadly speaking, the types of surgery are the same. When I think about surgery for breast cancer, there's two components. There's the operation that we do on the breast, and there's the operation that we do on the lymph nodes or the axilla. It's all done at the same time, but I like to talk about them separately to help explain what's happening. For a breast perspective, we're generally thinking about mastectomy, or partial mastectomy is breast conserving surgery. So a mastectomy involves removing the whole breast, and that can be done as a simple mastectomy. So a woman has the breast tissue removed along with the skin, and it's closed flat, or as flat as we possibly can make it, to make wearing a prosthesis in the bra easier. If we're looking at reconstruction options, and we're looking at doing particularly immediate reconstructions, we can sometimes save the skin with or without the nipple to facilitate that reconstruction. There can be a number of reasons that we look to do a mastectomy as opposed to breast conservation. And it's generally related to large tumours relative to a woman's breast size. If you have multifocal disease or more than one spot in the breast that can't be removed by just removing part of the breast. There's a very small group of women who are unable to have radiotherapy. There can be women who have already had treatment for breast cancer with a partial mastectomy and radiotherapy who develop a second breast cancer and need to have a mastectomy in that context. There can be specific reasons around risk, particularly for genetics, where we may recommend a mastectomy. And in a number of situations, it's a woman's preference. The preferred option is to remove the breast. Now, breast conservation, we like to get a bit confusing, and we use a lot of different names for effectively the same thing. So a partial mastectomy, a wide local excision, a lumpectomy, breast conserving treatment, they're just different names for the same thing. And what we're trying to do here is to remove the cancer, because fundamentally the most important thing we do is treat your cancer properly. But if we can do that and leave you with as good a looking breast as we possibly can, that seems to be a good thing to do. So what we're doing in partial mastectomies is taking the cancer out with a cuff of normal healthy tissue around it, and then following it up with radiotherapy. The radiotherapy is a really important part of a breast conserving approach, because without it, the chances of problems coming back in the same breast, what we call local recurrence, is just too high. I tend to think of situations where we wouldn't do a breast conserving operation. So if we can, we like to do it. And I think of situations where we can't do it. So as I've mentioned before, if the size of the cancer relative to the size of a woman's breast is such that what we take out means that what we leave behind is not going to look any good, we might need to do a mastectomy. If there's more than one spot in the breast or multifocal, we can't treat that by removing just part of the breast. And I mean, fundamentally, one of the main reasons, if not the main reason we do breast conserving surgery, is for a good cosmetic outcome. So if we can't achieve a good cosmetic outcome, we do need to think a little further afield. Anytime you're just removing part of the breast, I think it's important too that women know that sometimes we find that we don't have enough of a clearance around the cancer under the microscope, and there can be a need to have a second operation to achieve clear margins. And that can occur anywhere up to 15 to 20% of women. So potentially up to 1 in 5 women might be needing to have a second operation. And you might have noticed in the title I was referred to as an oncoplastic breast surgeon, and there are a few of us about now, and it might be something that people hear about from friends or find in their reading. Essentially, that's just us stealing some of our plastic surgical colleagues' techniques to treat breast cancers. And it's designed to improve cosmetic outcomes. And we're generally talking about this separately from breast reconstruction after a mastectomy. It's different ways of doing a partial mastectomy. Things like fat grafting or using breast reduction techniques, what we call a therapeutic mammoplasty. And that can involve operating on the other side to even things up as well. So it certainly is available around New Zealand, but not in all hospitals. It depends on the surgeons in different hospitals as to what may or may not be available. One of the things I often find is that there can be a view from women that a mastectomy is a more aggressive surgical approach to treat a breast cancer, so therefore it must be associated with better survivals and it might decrease the chances of needing chemotherapy afterwards. And what I say to women is that when we're thinking about systemic treatment and survival outcomes, it's not the breast surgery per se that has that impact. So we will be recommending chemotherapy based on the cancer, not the kind of surgery that we've done. And in fact, there are some international studies now coming through that show that breast conservation and radiotherapy is associated with a higher overall survival than mastectomy, and that's been shown in some recent data that's been reported. A nice way to think about it is that for women where breast conserving surgery or partial mastectomy and mastectomy is an option, given that breast conservation could potentially offer a survival benefit here, we do like to try and prioritise breast conservation over a mastectomy if they are both valid options for a woman. But it does require a pretty complex conversation with your surgeon, and I think feeling comfortable with the person that you're talking to and the information you've been given is, in my opinion, pretty important. The reasons for surgical recommendations can be really complicated and very different for different women. And so there's lots of factors that need to be taken into account, including the type of cancer, family history, and your personal preference. So it's important to really know why the decisions are being made and why they might be right for you. We recognise that cosmetic outcome is really important. And so although our priority is always going to be treating the cancer properly, when we're thinking about planning the surgery, where we place our cuts and what we're doing, we really do prioritise a good cosmetic outcome where we can. And so that was covering off some of the breast. The other thing that we're doing in the surgery is finding out more information about lymph nodes, because whether or not there are any cancer cells in the lymph nodes is one of the most important factors in terms of what we call prognosis. And most patients these days will be having something called a sentinel lymph node biopsy. So the sentinel lymph node is like the guardian lymph node of the breast. It's the first 1 or 2 lymph nodes that will drain the patch of breast tissue where the cancer is. And if they're the first lymph nodes that the cancer would spread to. And so we can specifically target those and remove them by using some dye injections. And that usually, but not always, involves 2 different types of dye: a radioactive isotope, which is injected before surgery, either the morning of surgery if it's in the afternoon or the day before, and then some blue dye injected into the breast when you're asleep. And we can remove those and send them off to the pathology doctors to look at specifically. The reason we like to do a sentinel node biopsy is it's the least invasive surgery to get the information we need to about the lymph nodes, and it's associated with a lower risk of lymphedema in particular. So an axillary node dissection is in the same area, taking out a pocket of fat containing a whole lot of lymph nodes, and we tend to limit this operation for women we know have had confirmed cancer cells in those lymph nodes before we do hit the operating theatre or do any surgery. It's a bigger operation than a sentinel lymph node biopsy. The number of lymph nodes we remove during that operation depends on the patient. I've done the same operation and removed between 9 and 42 lymph nodes. So there's a lot of individual variation there, but the average number is around about 15 to 20. We'll then, we talked about central lymph nodes and cancer cells. The one thing I would say as well now is even if there are some cancer cells in the lymph nodes after a sentinel node biopsy, not all women will need to have further axillary surgery. So that's a conversation to have with your surgeon as well.
Great, thank you, Alika. There was loads of information there. Just zoom back out there. Just to really overload you all out there with information, we're now going to hear from Nurse Katrina Farrick. She works here at Breast Cancer Foundation, so if you've ever called our nurse line, you may have actually talked to Katrina already. Katrina, how can people best prepare for their breast cancer surgery, and what do we all need to know about recovering afterwards?
Thanks, Adele. Yes, I'm one of the nurses at the Breast Cancer Foundation, and as Adele has said, some of you may have spoken to me on the phone if you have rang our 0800 advice line beforehand. Basically, you've heard already about the surgical options for breast cancer surgery. And so I'm going to focus from a nursing perspective on how you can best prepare for your hospital stay and also plan for your recovery at home. Now, the advice that I'm going to give you and some of the tips are from years of working in cancer nursing, but actually some of the credit has to go to some of the patients who have rang in and spoken to us about the different tips and advice that they had found useful. So Alika, as I said, has spoken about different types of breast cancer surgery. Before you have your surgery, it is really important to have a full understanding of the surgery you're about to have. Ask as many questions as you need, know who to ask those questions to, and actually also find out what is the best way to contact that person. Take time to make your decision. The majority of breast cancer surgeries are not urgent, and you do have a few weeks before you have your surgery. So if you need to go back and check some facts or details, take time to do that and make sure that you're making the right decision for you. If you want to have your breast tissue returned after your surgery, talk to your breast care nurse or your surgeon and they can organise that for you. Preparing for your hospital stay. So the preparation you do depends on your type of surgery. If you're having a lumpectomy, you may only be in hospital for a few hours or part of a day. A mastectomy often involves a 1 or 2 day stay in hospital, whereas if you're having a reconstruction at the same time, your stay could be much longer. Now, we do have some really good fact sheets available, and the fact sheet will be available online at the same time as the webinar goes live, but you can also call or email the breast care nurses and we can send one to you. Most of the tips are common sense, but you know, some of them are things like exercise as normal before your surgery, eat well and try to rest, stay as healthy as you can. If you're going to have some arm restrictions following your surgery, it's a good idea to move some frequently used items to lower cupboards or shelves and organise transport to and from the hospital. When you're packing for your hospital stay, things like sleepwear, ideally separates and front opening are a good idea. Now, front opening is a good idea, plain and simply because if you have drains and after your surgery, your nurses will want to check your wounds frequently. And so having a front opening top is much easier for them to access it and means you don't have to move around as much. Pack things like dressing gowns and cardigans, comfortable clothes to wear when leaving hospital, and things like slippers or slides. If you're going to need a post-surgical bra, ask your breast care nurse about this and pack them if you need to. Pack your regular toiletries, as these are not provided for you in the hospital. Take a list of your medications and supplements with you. Some medications may need to be stopped a few days before surgery, and actually some complementary therapies or supplements also need to be stopped a few days before surgery. So it's a really good idea to ask about these. And then there are some extra comfort things that you can pack as well, but these are all on the list or on the fact sheet. I'm just going to go back actually to that list. One of the really good tips we've got from patients is a mobile phone charger, an extra long mobile phone charger. And these can be got from the likes of the warehouse. If you think about when you're lying in a hospital bed, all the plugs and sockets are actually behind your head and it's really difficult to reach back and get your phone. So the long mobile phone charger is really good. And also a pen and piece of note paper. You will always remember the question you wanted to ask as soon as your surgeon, your breast care nurse has left. So write them down and at least you've got them there handy for the next time. On the day of the surgery, so you will be admitted to the ward and prepped for your operation. This includes things like putting a gown on, having a wristband put on, and answering what seems like the same questions over and over again. If you're having a sentinel lymph node biopsy, you may need to have another appointment to have the tracer substance injected before your surgery. And I think Aletha has already spoken about that. This substance does make it easier to find the sentinel lymph node. After you wake up from your surgery, so you may feel sleepy or drowsy after you wake up from the anaesthetic. You will be closely monitored by a nurse who will check your vital signs and your surgical sites very regularly. Please do let the nurses know if you have pain, nausea, or any other concerns. It is easy to address these, but the nurses are not geniuses and they won't get it. Dressings will be covering your surgical sites, and again, these will be checked regularly. Depending on your surgery, you may be wearing oxygen or have a drip, and you may also have some drains. Again, these will be monitored closely. If you have had blue dye injection during your surgery, your urine, your feces, and even your tears may be bluish green for up to 24 hours. Going home from hospital. Your hospital stay may vary, as I said, from a few hours to a few days. Before you go home, you will be given a follow-up appointment and some discharge papers. Feel free to go through these with your ward nurse before you go home. A copy of your discharge papers will also be sent to your GP, so they will be fully up to date on what's happened during your hospital stay. A prescription for medications and instructions on how to take these will also be given to you. Again, take time to go through all of these medications and the instructions. You can also talk to your pharmacist when you go to fill a prescription, and actually some people find it's a really good idea to have a pen and write on the box of medications in the pharmacy so you've got everything clear. A referral for a district nurse may be needed if you're discharged with a drain or some drains still in place. Now, for some people, and again it varies from place to place, for some people they will have quite a large drain bottle after surgery, and more often than not it will be changed to a small little drain like this called a rocket drain or a grenade drain. The nurses will go through with you how to empty those drains, how to care for them, and how to record the daily totals. A really good tip is to ask the nurse that's talking you through this if you can record this on your phone, like a short little video on your phone. And at least then if you run into any problems when you're at home or you're not sure of the instructions, you can refer back to this. And face it, most of us are actually quite drowsy after an anaesthetic, so it's hard to remember. But the drain will look something a little bit like this. A district nurse will come and they will help you look after it. If you have had a mastectomy, you may be given a softie, which is a little temporary prosthesis, and that just fits comfortably into your bra until you can organise a more permanent prosthesis later down the track. Recovery from your surgery. It may take 2 to 3 weeks for your skin to heal. Stitches will take around 6 weeks to dissolve. Initial bruising or swelling should resolve over the first few weeks. Do take painkillers as prescribed or as needed. If you find they're not working or they're not good enough, go back to your breast care nurse. If you find you need some more, again, go back to your breast care nurse and they can organise a prescription for you. You may experience some tingling, pins and needles, numbness, or a feeling of tightness around the scar. The tingling, pins and needles and numbness are due to some nerve damage during the course of the surgery. The tingling and pins and needles should actually resolve over a short little while. The numbness can be a bit more long-standing for some people, especially if you've had some axillary node surgery. Axillary node clearance. Ask your surgeon about taping or moisturising the scar. Now, it does vary from place to place, and some surgeons have different preferences, so please do ask what your surgeon would like. Please don't tape or moisturise or do anything with the scar before you actually go back and see your surgeon for the first follow-up appointment. Do your arm exercise as prescribed by the hospital physiotherapist. Again, this varies from place to place. Sometimes you'll see a physiotherapist on the morning of your surgery, sometimes it's after your surgery, and they will give you a list of exercises to do. Potential complications from your surgery. So we already discussed bruising and swelling, which will resolve slowly over a few weeks. A seroma is a build-up of fluid under the surgical scar area. It can feel a bit tight, or some people say it feels soft and squishy. If you feel you have a seroma, check with your breast care nurse. They may want to monitor it, or actually they may even need to drain it. A wound infection is something that nobody wants and you shouldn't expect, but if you think your wound might be infected, if it's sore, if it's red, if it's hot, if you're feeling hot and shivery or generally unwell, let your breast care nurse know. Change in sensation is something that we spoke about a little while ago. Skin discoloration from your sentinel lymph node biopsy. If you've had a blue dye injected in theatre, you may have some skin discoloration up through your breast for a couple of weeks to sometimes a couple of months after that, but it will go away, it will fade. Cording, Greta has already spoken about the cording, and we can actually provide some physiotherapy funding, and physio does really help with this cording. The cording is from damage to the lymph vessels during the surgery. Lymphedema is another possible long-term complication from your breast cancer surgery. It is more prevalent if you've had an axillary node clearance, but your breast nurse or your surgeon will discuss your risk of lymphedema with you. We do have a really good webinar separately on lymphedema where you can get lots of useful facts and information, and we've got some great information on our website as well from it. Ongoing pain can be an issue for a minority of patients. If this is something that affects you, let your surgeon or your breast care nurse know. They can discuss treatment options for you. Now, when you go back to your follow-up appointment, so most people will be given a follow-up appointment between 2 and 3 weeks after your surgery. At that follow-up appointment, they will discuss the results from your surgery. This will include what your pathology report says, whether your tumour is hormone receptor positive and whether you'll need additional treatments as a result of that. It will also be whether they've had clear margins from the surgery, all the cancer's been removed, and if there's any cancer in your lymph nodes. Ask, what are your next steps from here? Will you need to be referred to oncology? And if so, how soon should that referral happen, or how soon should you have an appointment? If you've got any questions ongoing, who do you ask? And again, how do you contact them? How do you organise a prosthesis, and how long should you wait before you get one? Now, we have little knitted knockers that are knitted kindly by volunteers, and these are a great substitute to sit in place inside your bra until you get your more permanent prosthesis. The Ministry of Health have funding available for prosthesis and post-surgical bras. This can be renewed on a 4-yearly basis, and your breast care nurse will give you a form like this with the medical certificate, and then you can organise that prosthesis. We can also talk you through that on the phone. Most people suggest you should wait about 6 weeks before you look at getting the prosthesis, just till all the healing takes place or starts to settle down. For some people, it can be a little bit longer, especially if they need radiotherapy. And if you've asked for your tissue to be returned, just ask how soon that will be and what the process is for this. Lastly, some supports that Breast Cancer Foundation can provide. We have got our specialist breast nurse advice line. Please call, leave a message if there's no answer, and we will get back to you. We provide funding for physiotherapy for recovery. This can be really helpful to get back the range of movement, recover strength, and actually help with pain and alleviate things like hoarding. We provide some funding for lymphedema assessment and treatment for those who need it. We also provide some funding for counselling. Now, being diagnosed with a breast cancer, it's a huge thing. You know, it's not like going for surgery for a hip replacement or a hernia. There is a lot of stress and trauma around that diagnosis. And for some people, they're so busy with tests and appointments in the lead up to their surgery. They get through their surgery, come out the other side, and sometimes it's quite a little bit down the track before the enormity of the whole situation does actually kick in. This is okay, and this is normal. And recovering from breast cancer surgery is not just physical recovery. There is emotional recovery and psychological recovery as well. So give yourself time, you know, take some time out for you and actually look for some support. We have got some, speaking of support, we've got some support aids as well, heart-shaped pillows and some drain bags, which again are really kindly made by volunteers. These are really good. Breast Cancer Foundation can send you some of these for free. The heart-shaped pillow literally just tucks up under your arm and provides really good support for the tender post-op areas. We've got MyBC, which is our online patient community. This is a really good place for getting support from other women or other women and men, and also telling your story. And we have got plenty of other webinars that cover lots of other breast cancer topics on our website, and plenty of information on the Breast Cancer Foundation website.
Great. Okay, thank you, Katrina. There's, again, a lot of really helpful information there. And so it will be good to, we will be sending you a link so you can watch that again if you haven't caught everything. But now we're going to switch over to answering some questions from you at home. If you haven't already, you can type your question in the chat box by clicking on the icon on the bar at the bottom of the screen, and we'll just start working through those now. Katrina, could you send the vote back to me? Thank you. That's great. Okay, so let's take a look at what we've got here. Okay, so a question about, let's see where we start. Start with people having a preventative mastectomy if they've got a BRCA gene. Couple of questions on that. When would you realistically start to feel a sense of normality after a prophylactic mastectomy? Does it make any difference, Aletha, what the purpose of the mastectomy was?
I don't think you can set a time frame on when a woman's going to feel normal after this kind of surgery. I think there are some set time frames around physical recovery, but I think this ties into what Katrina was saying about the emotional impact, and it is, in my experience, very, very variable for different women. And I think any woman losing a breast for any reason, it's a traumatic experience. One of the things I think that's a little bit different around risk-reducing surgery for people with genetic mutations, particularly BRCA mutations being the most common, is that in that context, you, generally speaking, the decision around risk reducing the surgery in that context is driven by the woman themselves, because unlike ovarian, the ovarian risk, we do have non-surgical risk surveilling strategies, and so we can do high risk surveillance and give time for women to get their head around what's potentially coming up, and so I think that ties into how you can manage the psychological impacts of the decisions that you're making, that you don't necessarily have the luxury of if you're going through a cancer treatment and diagnosis and part and parcel.
And there's some questions here about the sort of practical side of that, and perhaps you can chip in on this one too, Greta, around starting to be able to do things like cooking and washing your hair and important things like that afterwards.
Well, my personal thing, like they said, you need to wait a good 6 to 8 weeks for recovery. I'm a doer, I'm active, and so 1 week felt like an eternity, but I was still in a lot of pain, couldn't do a lot, couldn't lift my arms a lot. So that's why you do need to have help, have a support person at home. And so even for someone who I was, strong, capable, etc., I still needed help. I started to get really impatient around the 4 week mark because I felt the same, and I thought it's not working, why am I not feeling better by this stage? And literally between the 6 to 8 week mark, everything started falling into place and started feeling better, other than the physio, which made a huge difference. But separate from that, all the other pain, wound sites, being able to lie on your side and not only on your back and things like that, it kind of just all magically, it did change around the 8 week mark and so you do need to trust your surgeon when they say wait 6 to 8 weeks. And I was like, no, that's a lifetime and it's taking too long, but it really did actually kick in. So just having help before then is quite important.
And Shana, was there anything that you felt you couldn't do after breast conserving surgery?
There was nothing I couldn't do. I could lift my arm up quite well. I was kind of cut from here through to here. So I could lift up my arms. So I was quite lucky in that way. I think I was just being super careful in the shower.
I think the reconstruction choice also ties into it pretty heavily. So the recovery from an implant-based reconstruction is going to be different than the recovery from a DEP or a tummy tissue reconstruction. So, and often the recovery from the reconstructive component is actually a bigger deal physically than the recovery from the breast surgical component of it. And so absolutely listening to your surgeon in terms of that guidance of time frames, because there's individual variation, but 4 to 6 weeks after a reconstruction is a good starting point. When it comes to seeing women I see most of my patients about 2 weeks after their surgery. And one of the things that I like to do if I've done an axillary operation is just to ask how close they are to brushing their hair, because I'm going to want to have my patients able to do this sort of thing at 2 weeks. And if they can't, that's a gauge for me that I need to be thinking about an earlier physiotherapy referral.
Okay,
So
that's very helpful.
Mm.
Great. Katrina, question for you. Can people having a preventive mastectomy, the BCFNZ again, have free physio through the Breast Cancer
They
Foundation?
can have all of our support services through the Breast Cancer Foundation, absolutely.
Great, thank you. And so to get that, they can call.
So they just call us on our nurse line, or they can email us. They can also find a physiotherapy referral that they can self-refer on our website. We do have some information as well about genetic health and family history on our website if they would like to check that out.
Great, great. Okay, now a question about node removal, having lymph nodes removed. If you know how many nodes are involved because you've had a PET scan, does this determine the number that will be removed?
No.
Okay.
Even if you know how many lymph nodes you have from a PET scan, it's not quite as straightforward as being able to identify exactly those lymph nodes that light up on a PET scan when you're removing them surgically. And a lot of our decision, and even a PET scan won't necessarily pick up things at a cellular level. So once you know that you've got lymph node involvement, some of the surgical decisions are around what has been shown to impact survival and provide survival benefits long term in terms of reducing risk of loco-regional recurrence, and it's just not technically possible to be able to cherry pick and identify those lymph nodes. What we can do sometimes is put clips into involved lymph nodes for our patients having neoadjuvant chemotherapy and do targeted operations if they have an excellent clinical and radiological response. But generally speaking, if we're looking at axillary dissection, we do a standard level 2 dissection.
Okay, and talking about clips and things like that, what exactly is a hook wire?
Right, so if we're doing a breast conserving approach or a partial mastectomy for a woman where we can't feel the cancer, we have to have some way of guiding us to which bit of breast tissue we need to remove. And so a hook wire is placed on the day of surgery under radiological guidance, either via mammogram or ultrasound, to help direct the surgeon as to which bit of breast tissue contains the cancer, to help guide which bit of breast tissue we need to remove. Hook wires are the commonest way of localising non-palpable cancers, so breast cancers that we can't feel in women who are having partial mastectomies or breast conservation. There are some other techniques becoming available, so there are some centres where radioactive seeds are used or carbon tracking may be used. They're just different ways of guiding the surgeon as to which bit of breast tissue needs to be removed if there's not a lump to feel.
Right. Did you have a
Yes, I did.
Shona?
I had that. Yes,
And when
I
was
did.
that done?
It was actually done on the day of the surgery.
Great. Okay, and was that any discomfort or anything
No,
like that?
no, not at all.
Great, great, thank you. Okay, now a question now from someone who's been diagnosed with DCIS. I've been recommended a mastectomy on my left breast. There are 3 areas of concern in the breast. I hadn't heard of this before my mammogram and feel that more needs to be known. And she's very happy with her care, but says this just feels like a real shock having to have a mastectomy with a DCIS diagnosis.
It often is. If you're not there, I would recommend going and having a conversation with your surgeon again. But if you have more than one spot in the breast which is involved, that is that scenario where it's just not technically feasible to remove all the area we need to remove just by removing part of the breast. But it can be really confronting to have a precancerous problem like DCIS that needs to be removed and be needing to think about something as major as a mastectomy for that.
Adele, just to remind you as well that we do have the webinar on dealing with DCIS, which that listener may want to actually go back and watch and look at as well.
That's a great suggestion. Thank you,
And
Katrina.
with all of these situations, but particularly with DCAs, I think this ties back into having time to make sure that you are comfortable with the decisions that are being made is really important.
And so what is a sort of acceptable weight for breast cancer surgery? And how do you figure that out?
Well, it depends on the cancer. It really does. There are, and I suppose that's one of the big changes with neoadjuvant chemotherapy as well. For our higher risk cancers, we are looking at getting treatment in the form of chemotherapy started sooner. So the cancers that we want to be operating on particularly quickly are the more aggressive cancers, and they tend to be the ones that we are thinking about neoadjuvant chemotherapy for first. The other issue that we have around timing and treatment is that there are Ministry of Health targets that we are required to meet. So that can be one of the drivers and the pressures to get on and get treatment started. We need to be looking at surgery, certainly within the public sector, within 6 weeks of diagnosis. That's a very difficult question to answer. There are patients that I am very comfortable waiting 6 weeks to have their surgery if that's what we need to do to coordinate reconstruction, and there are other patients that I am uncomfortable with that for, and it really ties into what we know about the cancer before we operate. So sorry, I can't give a more definitive answer on that one.
And I think a lot of it is the fact that, as Elise said, there are different types of breast cancer. It isn't just one specific disease, and so it really does depend on your particular type of cancer, and only your surgeon can really answer that.
What I can say is it's my job as a surgeon to be clear about what I think particular risks are for an individual patient. So I do often have conversations with patients, and I will be very clear in my guidance and say, I think this time frame is acceptable and safe from a cancer treatment perspective, or no, I'm very uncomfortable with this, we need to get on things sooner. So that is, if you're concerned about timeframes, once again, having a talk with your treatment team, they should be able to be clear with you about what their concerns are.
Right, okay. Now, this is an interesting question. If I'm having surgery privately, how can I line up being under the care of a breast care nurse?
I work in a private practice where we have breast care nurses as part of our specialist team, but I also am well aware that I work in a private practice in a big centre. If your private surgeon does not have a breast care nurse that they work with regularly, and I would ask my private surgeon about what access is. Generally speaking, if they don't have access to a breast care nurse, I think they would be fulfilling a lot of that role themselves.
And I think that is one of the real strengths of our public hospital sector, is that the early breast cancer diagnoses, the access to a breast care nurse. Shona, you were in private.
I was in private. I didn't have a breast care nurse.
So your surgeon was your first point of contact for anything.
That's right.
And I think people often don't sort of know they've missed out on that perhaps until later. Did you have access to a breast care nurse? Were you happy with how that was?
Well, I loved my first nurse. She was super helpful. But then when I got transferred with for the chemotherapy treatment versus being at the super clinic, that nurse supposedly was my point of contact, but no, it wasn't good. So I kept actually staying in contact with my first one, who would then help me out and refer me. So again, it is, you definitely need someone. You do need a nurse. It was very helpful, but I had to go back to one who wasn't meant to be because the other one wasn't.
I think it's really important to reiterate the fact that the breast care nurse that you have in the hospital should be your first point of contact. Plain and simply because they have access to all of your notes, all of your medical history and everything that's pertinent to your particular treatment. we do have specialist breast nurses at the Breast Cancer Foundation. So if there are any questions or queries, or there's something that you want to run by, we are always more than helpful. I'm more than willing to be helpful and take a phone call or answer an email as well. So if you don't have a breast nurse in private and you do have some questions, we don't have access to your medical notes, so we can't be so specific on the instruction we give, but we are more than happy to be supportive.
And the other thing I would say is that as a breast surgeon, and I think of the breast care nurse as the surgical breast care nurse. And so my patients will have a breast care nurse as part of their surgical treatment, and that is both in public and private. There is a separate nurse specialist that becomes involved with the oncology component. And I will always say, look, sometimes you might have 2 points of contact, and you can always ring us, because if we're not the right person, we talk a lot in the background. There is a free flow of information with your breast specialists, and it's very easy for us to get on the phone and direct to where things need to happen. So
great. Now we're sort of running out of time. We've got quite a few questions left, so we'll move briskly on. What is the time frame for the surgery to happen after finishing neoadjuvant chemo?
4 to 6 weeks is the time frame we like for it to occur, and so you need that 4 weeks to recover from the chemotherapy, because we don't want to be operating on patients whose blood counts are too low. We tend to make it around the 5-week mark, and the reason for that is a lot of it, particularly if we're looking at reconstructions, coordinating that and having all the people in the room that need to be in the room is quite a logistics exercise. And so there are potentials for delay if people's chemotherapy is pushed back. And so if we're planning for our complicated reconstructions to be happening at the 5 to 6 week mark, we don't run into any problems if chemotherapy is delayed a couple of weeks.
And would that reflect your experience?
Yes, that would be right for me.
Yeah, so yeah, same for me. I think I was booked in basically 5 weeks to the day.
Right, great. Okay. Now, what reconstruction options are best if you've had a double mastectomy and it's now a year since surgery, treatment and radiation?
Okay, so the keys for me from that are the year since surgery and the radiotherapy, which tends to mean that you don't have the breast tissue skin, and the radiotherapy tends to mean we're talking about what's called autologous reconstructions. So that's just fancy doctor speak for using your own tissue, and that will depend on what tissue you have available. It's normally tummy tissue or back muscle with latissimus dorsi and an implant reconstruction. But there are pros and cons to those different approaches, and sometimes there also, particularly with the tummy tissue, there is a limit to the amount of tissue a person might have as well. So you're thinking a latissimus dorsi or a tram/DIET reconstruction, but it certainly needs a conversation with the plastic surgeon.
Great. And if I'm having direct to implant reconstruction post-mastectomy, when can I hope to have good-looking breasts physically?
Straight away.
Straight away.
Great. That's a good, quick answer. And we've just got a couple more minutes, so a couple more questions here. When you have ER positive and PR positive breast cancer, how many people have to have hormone treatments for that? What's the rate of having to go on to hormone treatment?
Pretty high. You have to have a very small, very favourable cancer to not be recommended endocrine treatment in that context.
Yeah, and certainly the international guidelines basically say everybody should have it. So if you're trying to skip that, you might be out of it.
We will recommend it for almost all in that context.
Are permanent implants softer than temporary expanders?
Yes.
And what are expanders anyway?
Speak from experience. I currently have expanders in, saving my skin ready for reconstruction, and they don't move. So it's like having hard rocks in you that don't move, but you look normal, and after you get used to them and the firmness of them, it actually doesn't matter. And so I've been told that in you can, yeah, so I've been told that once you get your breast implants in, they feel a lot more natural and softer, but these also, I've been told, are fine. They're not life-threatening. They're there. They're doing the job. And so my other surgeries and treatments come first because the life-saving part's been done. So I'm actually stuck with these for longer than I thought I'd be, because finding out I needed more chemo and stuff. So yeah, you do get used to them. So yes, they are firmer, but it's no biggie.
So an expander is like a silicone bag that you normally fill up with sterile saline, so salty water. And often when you're doing an implant reconstruction, you can't put a full volume breast implant in. So the expander enables you to inflate things over a period of time. They tend to be fuller up the top to start with, and they tend to be a lot firmer than a permanent implant. And there are different types of permanent implants that can feel a little bit different as well.
Do you know, we had a lady that I spoke to, and she said that her expanders, the way her surgeon explained it to her was, you don't go from being newly pregnant to 9 months pregnant at the same time. Your tummy stretches slowly over time as baby grows, and the expanders are injected and filled just to allow your breast to do the same thing before you replace it with a permanent implant.
Right. One last question. Aletha, can you share some thoughts on tram flap reconstruction, how this affects the core muscles long term? What exercise you should avoid? Is that...
All right. So I will state for the record, I'm not a plastic surgeon, and so it's my plastic surgical colleagues that do most of the do most of the autologous reconstructions. So a tram reconstruction, so when you're looking at a reconstruction, and if you're talking about a tram or a DIEP, the volume of the breast reconstruction is the fat in the skin, and the tram bit or the DIEP is how you get the blood supply, and that blood supply goes through the muscle. So a tram flap basically takes some or all of that muscle and flips it up to enable the fat and skin to get to the breast or where the breast was. And that means there will be a weakness where that muscle was. And so that can substantially, it's what we call a donor site defect, and it can cause some significant weakness of the abdominal wall on that side. Depending on how physically active you are will depend on the degree of symptoms that you get from that. It's also one of the reasons that the plastic surgeons prefer to do muscle sparing techniques and either take as little muscle as they can, or more commonly a DIEP, which is for a lot of women, their blood vessel anatomy is such that the plastic surgeons can just take the blood vessels and then use microscope surgery to plumb them into blood vessels in the chest to minimise the impact on the abdominal wall muscle and strength.
Right. Thank you. It does.
You know, webinar to answer that one.
I know, it was hard talking about breast surgery in 12 minutes.
And we do have another webinar on reconstruction techniques, and I think you were speaking on that one too, Aletha.
Was I?
So there's more to have a look at there. So our time is up for tonight. Thank you very much for joining us, all of you at home, and thanks again to Shona and Greta and Aletha and Katrina. You've all been fantastic. Thank you also to our producer Julia, who's kept us all online and on time tonight. We hope you all found this helpful. When we close the webinar, you'll be redirected to a short survey, which we really appreciate you filling out with your feedback on your way out. And if you do have any questions about breast cancer surgery or any other aspect of breast cancer and treatment, our nurses are available to take your calls during office hours. The number is there on your screen, and it's also 0800 BC Nurse for your info. In the next couple of days, we'll send you a link to the recording of the webinar. Oh, there's also a link to our a reference to our online community there, where you can connect with other people who might be having the same questions and the same procedures that you are. We will send you a link to the recording of the webinar. If your question wasn't answered tonight, I think there was one that we'll get back to you on that, and if we don't, please call the nurse and ask that question. Thank you again for joining us. See you next time. Good night.
Good night.
Good night.